Hi, I'm Jack Cush, Executive Editor of RheumNow.com. Today is the 16th of September, and this is the RheumNow Week in Review. A number of interesting items this week. More news in our journals and our reports about the hazards and costs of narcotic abuse in the United States. It's obviously been a big problem in the last decade. The numbers are either 40 or 44 patients dying per day from narcotic overdoses. And that the estimated cost in a recent report to our society is estimated to be $78 billion in the United States. So again, this is a major problem, major cost for our society. Olga Petrina, one of our reporters, reported and tweeted about the new rituximab biosimilar called CTP-10, a Celltrion product that has been shown to have equal and identical efficacy, pharmacodynamics, and safety and immunogenicity compared to its original product, Rituxan. So look for that coming up in more reports and maybe the next year or so FDA approval. A nice review from an obscure source, but nonetheless a nice overall review of the issue of TNF inhibitor-induced psoriasis. The literature says that it's roughly a 1 in 1,000 risk. Many of us who see such patients suggest it could be as much as 1 in 100. But nonetheless, this is a rare event with no clear understanding. They review the pathogenesis and potential etiologies that underlie this, and they also address the issue of treatment, wherein the best treatment is stopping all therapy, and that seems to work best, especially in people with palmopustular psoriasis, which is one of the most common presentations of TNF inhibitor-induced psoriasis. But you do have other options, and that would include changing from one TNF agent to another. The problem with that is that there's a fairly high relapse rate. They quote a number of 48 to 85% recurrence. And then some of us, including myself, actually have used the ustekinumab to manage such patients while maintaining their TNF inhibitor, which is helping them. Still remains to be seen the optimal way to treat such patients. I wrote a blog that was all about disease activity. It was called "It's the Engine That Kills You, It's Not the Caboose." It's a line taken from a movie. And it's all about discussions that surround the issue of drug safety and some of the hazards we deal with in using advanced therapies and biologics. Often the discussion centers around the risks associated with the drugs, but in this particular blog is all about, we should be talking about the disease activity of RA, and that RA disease activity drives cardiovascular risk, drives infectious risk, drives cancer risk over and above and way before the use of any biologics. So it is the engine that kills you, it's not the caboose. The EMEA in the last week has granted orphan status to a new drug for scleroderma, especially scleroderma patients who have interstitial lung disease. The drug is a kinase inhibitor called NINTEDANIB, nintedanib. This is always a hard thing getting started with these new drugs. Nintedanib is a new kinase inhibitor that is approved for patients who have interstitial lung disease, and now it's got an orphan status. There is a trial that's just started up and is not yet fully enrolled, looking at the use of this drug in scleroderma patients with ILD, so more to come, but yet it still is out there for patients who have severe disease. Another study about scleroderma looked at the GI manifestations of scleroderma, looking specifically at the Mayo cohort, where they studied a large number of patients and showed that the most severe forms of GI dysmotility were seen in patients with diffuse disease, much more so than patients with limited disease, but nonetheless that a sort of pattern of scleroderma disease with esophageal involvement is seen in up to a third of patients and seen equally. The safety of TNF inhibitors was addressed in looking at the recurrence rates of head and neck cancer. 180 patients with head and neck cancer who went on to receive either a TNF inhibitor or a DMARD were followed over time, and it showed that the TNF inhibitor did not increase the risk of recurrence, with a hazard ratio of 0.75, although it did cross 1, suggesting it was not significantly lower, but it was in fact the same as those who got DMARDs, but if anything, it might be a little bit less. Earlier in the week, we reported the new CDC guidelines, CDIP guidelines, or ACIP guidelines about the flu vaccine for this upcoming year, 2016-2017. They remain the same in that they still recommend that you not use the nasal active live virus with FluMist, largely because it just doesn't work very well. This is a new vaccine with a new target. They have new guidelines on how to manage patients who have egg allergies, and you can receive the flu vaccine this year if you've had an allergy, including Guillain-Barré. But if you have severe egg allergies, minor egg allergies can just require being monitored for 15 minutes. The old guideline was 30 minutes. And that if you have severe manifestations with egg allergy, you can still get it. It just has to be in a hospital or a healthcare setting where patients can be treated and monitored. So it's not a total contraindication if you have an egg allergy. But again, most people don't use it, and that's probably not right. The reports that appeared in the news included today's report that from the MMWR and the CDC review of data acquired in 2014 showed that up to 31 million Americans over age 50 do not receive adequate levels of exercise. This is based on the BRFSS telephone survey that occurred in 2013. They showed some fairly large numbers, and obviously numbers go up with age and are different in different age groups. It's worth a look. A New England Journal report this week about a new form of inactive shingles virus vaccination called Shingrix, S-I-H-I-N-G-R-I-X. That's Shingrix. It's like shingles meets grits, and that's how you pronounce it, Shingrix. This is a subunit of herpes zoster that's used in vaccination in two studies called Zoe 50 and Zoe 70. Zoe 50 is adults over age 50. Zoe 70 is, and it's Zoe ZOE 70 is for adults over age 70, showing very impressive protection rates, over 90% in both populations, and not different in both populations. That's different than Zostavax, which is not as effective in an older population. And as far as prevention of post-herpetic neuralgia, no cases were seen in those under the age of 70, whereas those that were over age 70, 88% fewer cases of post-herpetic neuralgia were seen with this new vaccine. Expect this to hit the markets probably in 2018, if you're lucky, late 2017. And another important study comes up from the New England Journal that was about CPAP. You know, we all know about the risk of obstructive sleep apnea and causing hypertensive, cardiovascular events, et cetera, but there's never been an intervention trial with CPAP, and that's what they did in over 2,700 patients who had a cardiovascular risk factor, and they were either given CPAP or usual therapy for their sleep, which could have been no therapy, and they showed in both groups basically an event rate, cardiovascular endpoint event rate of 15 to 17%, and not significantly different between the groups, suggesting that CPAP won't prevent these cardiovascular events, and that further research and strategies are needed to avert that ugly outcome. So that's it for this week. Go to the website if you'd like to click on these links and find the original source material. We'll see you next week at RheumNow.com. Take care.